My name is Jennifer Lewis, and I'm going to do a neurological exam. This is my patient, Catherine Lewis. Can you please tell me your name, the date, and where you are?
Catherine Lewis. Today is the 25th of June, and I am at our apartment.
Yes, before we start our assessment, I will be taking your vital signs. Is that okay with you?
Yes.
Perfect. Let's say I have a blood pressure on this cuff, blood pressure, taking. Have a pulse on this cuff, great. I would listen, I could do all your heart rates, I could do stuff like that. You can count your respirations as all that's going on. I could take your temperature, it's 97.3. Your heart rate is 80, your blood pressure is 120/80. That's what my monitor says over here. And your O2 saturation is 98%. Now we're going to go on to the health history portion of the exam. Have you ever had or are currently having any type of headache, head injury, dizziness or vertigo, weakness, either generalized, proximal or distal, numbness, abnormal or loss of sensation, fainting or blacking out, seizures, tremors, or involuntary movements?
I had migraines when I was younger.
Okay. How severe were the headaches?
Very severe. I was put on medication.
How long were you on medication?
6 months.
Perfect. When did they start happening?
7th grade.
What was the location of your headaches?
Top.
Perfect. Okay, thank you for telling me. How long did they last?
The migraines?
Yes.
Anywhere from 15 to 2 hours.
And how long did you have the migraines before they were under control with the medication?
4 months.
Do you have any kind of associated symptoms such as double vision, visual changes, weakness, or loss of sensation?
Weakness on my right side.
Okay, we're now going to move on to the physical examination part of this assessment. There are 3 parts of this physical exam: the cranial nerve exam, the sensory exam, and the muscle stretch response, and the deep tendon reflex exam. In order to be effective during this neuro exam, I have already surveyed my patient's mental status and speech during the health history portion of the assessment. She was alert, she gave appropriate responses, she knew the date, the time, and where she was at in orientation. The first thing we're going to test is the cranial nerve, which is your olfactory nerve. That's going to test your sense of smell.
Okay.
So I have coffee and soap in these 2 cups. I'm going to compress the side of your nose. I'm going to ask you to sniff, and then we're going to do this to both of your nasal passages to just see the patency. Okay, it sounds like that side was a little clearer.
I have allergies.
Okay. I'm going to ask you to close both your eyes. I'm going to occlude one nostril, and I'm going to ask you to smell. And then I'm going to do the same with the other nostril, and you're going to tell me what scent you smell for both.
Coffee.
Yep.
Soap.
Yes. And we do this because if you assess your patient with the same smell, they're going to know it more than if you would with 2 different smells. The next nerve assessment we're going to do is the cranial nerve 2, which is your optic nerve. I would, in theory, use the Snellen chart to test the acuity of central vision, my patient's ability to see at a distance. Since I do not have one present in my apartment, I'm not going to use one. I would get my patient to cover one eye with her hand and attempt to read the chart. After that eye was completely done, I would get my patient to switch hands and eyes. So, for example, she would read the chart with one hand covering, and then she would read the same chart with the other hand covering. You would test both eyes. Next, I will examine my patient's optic disc. I will warn my patient this light will be very bright. And then I'm going to ask the patient to pick a point on the wall over my shoulder. I will be in front of you for this part of the exam. I'm going to shine a light into your eyes and look into a scope. During this portion of the assessment, I would dim the lights, but I'm not going to do that right now. Can I see your phone? Thanks. Now that I have this is my scope. I'm going to put this light in your eye. Please focus at a point over my shoulder and do not look. Ready? Perfect. Okay, I'm going to do it to this one. I'm going to do it so our noses do not touch. Perfect. Thank you. Can I scoot past you right here?
Yep.
Thank you. That was assessing my patient's optic disc. I could also do a visual field screening. I would instruct the patient to tell me when they see my hands. So I'm going to stand about 2 feet away and ask the patient to look with both eyes into my eyes. And I'm going to spread my arms just behind and lateral to the patient's head. And as I move my hands towards the center of her face, she's going to tell me when she can see my hands. And I'm going to wiggle my fingers. I will test this in both the upper and lower quadrants to obtain a better assessment. Would you mind standing up? Please tell me when you see my hands. They're going to be wiggling.
Now.
Thank you. That was my patient's assessment. Now I'm going to assess cranial nerves 2 and 3, the optic and ocular motor nerves. I'm going to inspect the size and shape of the pupils and can compare one side to the other. Can you please look at me? She has glasses on. I would ask her to take them off during this assessment, or this part of the assessment. Okay. Her pupils look equal and round. I would next test her reaction to light, which we've already done previously in this assessment, but I can do again. Can you take off your glasses this time? Thank you. Come in from the side. Awesome. Patient pupils are reactive to light and accommodation. Next, I will be testing cranial nerves 3, 4, and 6, the ocular motor, the trochlear, and the abducens. As we move on to this part of the exam, I will assess the 6 cardinal directions of gaze. Look for loss of conjugate movement in any of the 6 directions. I would also identify any nystagmus. So I would ask the patient to look as she normally would. So just look straight, or just look straight towards me. Okay. I would ask her to look up and down. Perfect, thank you very much. And then I'm gonna do the same. So look as you normally would, and then look lateral, and look up and down. Perfect, and then down. Okay, normal. And then can you do it the same on the other side? Yes. As she moves, I would look for nystagmus in any of her eyes. Both eyes had no nystagmus present. Next, I'm gonna have a tweezer. I'm gonna hold it 12 to 18 inches for my patient and check for convergence. So I have my tweezers, and I'm gonna move them towards her nose. If she has any type of nystagmus present, I would ask her to fix her vision on a distant object and observe the nystagmus increase or decrease. No nystagmus was noted. Next, I'm going to look for ptosis or drooping of the upper eyelid. As I can see in my visual assessment, she does not have ptosis. Next, I'm going to test cranial nerve 5, the trigeminal. I'm going to palpate the temple and the masseter muscles. Palpating the temple. Sorry, glasses are in the way. No, you're fine. You don't have to remove them. As I'm concerned for my patient's well-being, she would be more comfortable having her glasses on during this assessment. Okay, palpated those. I would also use a tongue depressor if I had access to one. I would use a sharp and dull end of a forehead tongue depressor to the forehead, cheeks, and chin. And I would ask the patient to report whether it's sharp or dull. Luckily, I do have something that is sharp on one side and dull on the other side. Do you mind if I use this during the assessment?
Nope.
Okay. We're going to start with your forehead. Please close your eyes. What do you feel? Sharp or dull?
Dull. Sharp. 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 Dull.
She identified every sensation correctly. Thank you. Next, I will do the corneal reflex. I'm going to ask the patient to look up and away from me and approach from the opposite side out of the patient's line of vision. I'm going to avoid her eyelash and touch the cornea with a fine wisp of cotton. I do not have cotton balls at this apartment, so I will show you what would happen in assessment. I want to actually touch your eye. Can you please stand up? I will demonstrate. Please stand over here. I would come behind my patient. I would have my wisp of cotton. And without touching her eyelid, I would touch her cornea right here. And that's part of the assessment. A normal facial reaction would include blinking of the eyes. She had blinking of the eyes. The next cranial nerve I will be assessing is the facial cranial nerve. To be efficient during this exam, I have inspected the face at rest during the conversation and have not observed any tics or abnormal movements. I will ask the patient to raise both eyebrows, frown, close your eyes, so I cannot open them, and then I will try to pry your eyes open. With one hand under the eye and one on top of the eye. Can you please take off your glasses for this portion of the assessment? Do not be nervous. I am a healthcare provider. I am here for your safety. Cut them tightly. As you could tell, I was not able to pry your eyes open. Can you show me both your upper and lower teeth? Thank you. Can you smile? And can you puff out your cheeks? Perfect. She's passed this portion of the exam. The next thing I'll be assessing is the cranial nerve number 8, the acoustic. I'm going to whisper something into my patient Catherine's ear, and I will rub my fingers next to the non-operative ear to see if she can differentiate what's happening. What did you hear?
This and you're whispering in my other ear.
You heard both of them at the same time?
Both at the same time.
Okay. I have assessed cranial nerve number 8. Next, I will assess cranial nerve 9 and 10, the glossopharyngeal and the vagus. I will assess my patient's voice.
Hello.
Do you have any trouble swallowing? No. I'm going to instruct the patient to say ah or yawn and watch the movement of her soft palate and their pharynx. Can you say ah for me? Okay. I have assessed those. The soft palate rose symmetrically, which is normal. Since my patient is healthy and her swelling is intact, we will not assess the gag reflex today. If you do not assess this reflex, if you are going to assess this reflex, please warn your patient beforehand. Next, I will assess cranial nerve number 9, the spinal accessory. I'm going to stand behind my patient. I'm going to ask my patient to shrug both of her shoulders upwards towards her face. And then I'm going to ask her to turn her head to the side against each of my hands. Can you please stand up? Can you please, yes. So assessing the strength. Can you shrug your shoulders towards your face? Very good. Can you turn your head into my hands? Perfect. Not your body, just your head. This is your spinal cord, not your body. Perfect. After some clarification, she did pass the assessment. Finally, I will assess the cranial nerve number 12. I'm going to listen to the articulation of my client's words. Hello. Can you say a few more words?
How is your day going today?
Patient has good articulation for a female of her age. I'm going to inspect the patient's tongue as it lies on the floor of her mouth. Look for any signs of atrophy. Looks good. No signs of atrophy noted. I'm going to ask the patient to stick her tongue out and move her tongue side to side outside of her mouth. And note the symmetry of the movement. Very symmetrical movement. If you were ever in an ambiguous case, I would have asked my patient to push the tongue against the inside of her cheek, and I would palpate externally for strength of her tongue. Next, I will assess the motor system. I'm going to assess for rapid alternating movements, also known as the arms. I'm going to instruct my patient to strike one hand on her thigh, raise her hand over, turn it over, and then strike it again. And do this as fast as possible. And I'm going to watch her do it. Thank you. I can also instruct my patient to tap the distal joint of her thumb with the tip of her index finger and do this as fast as possible. Yes. She's showing very good normal signs. I could also have her tap the heel, her heel, on the floor as quickly as possible. Yes. Thank you. She passed this assessment. Next, I'm going to ask her to do the point-to-point. We're going to stand, and this is called the finger-to-nose test. I'm going to have my index finger extended, and she is going to point to her nose and then touch my index finger, and she will do this several times. Ready? Yeah. Pretty good. Okay, patient's getting it every time. She passes as part of the assessment. She has displayed normal indications. Next, I'm going to ask the patient to walk across the room, turn and come back. I will observe her posture, her balance, the swinging of her arms, and the movements of her legs to see if they are normal. As you can see, she has good posture, a good gait. Everything is normal, no slouching. Next, I will have my patient walk heel to toe in a straight line. Please stay standing for the portion of this assessment. Heel to toe, please. Thank you. I'm going to watch her. This is very hard for balance. Okay, thank you very much. So as we see, there was a little unbalance noted. That's normal. Okay, and the patient is saying that it's normal for her. Next, I'm going to have my patient walk on her toes and then on her heels. This is a sensitive test for plantar flexion and dorsiflexion of the ankles, as well as for balance. Can you please start off by walking on your toes? Patient has good balance while walking on her toes. Can you walk on your heels? Patient shows good balance. There we go, thank you very much. Other tests, did you forget, include hopping in place on one foot, doing a shallow knee bend, rising from a sitting position without arm support, and stepping onto a sturdy stool. Well, we've already done 3. Next, we're going to do the sensory system, and we will do an assessment. You can come sit back down. During this assessment, I will evaluate various types of sensations, pain and temperature, position and vibrations, light touch, and discriminative sensations. We will start with pain. I will be using my tweezers again. During this assessment, I'm going to ask if this is sharp or dull. Can you please let me know? Can I have your hand? Thank you. Please close your eyes. Sharp. 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 Dull. Patient ace that portion of the exam. Thank you very much. Is there any sensory So for the next part of the exam, I would test for temperature and I would assess for any sensory deficits. I would use 2 test tubes filled with hot and cold water or a tuning fork heated or cooled by running water. I would touch the skin with a tuning fork and ask the patient to identify hot or cold. But because my patient has no sensory deficits, I will not be testing her on this. Next, I will be using a wisp of cotton. I will lightly touch the skin, avoiding pressure, and ask the patient to respond whenever a touch is felt and to compare the area with another.
I feel it on this hand.
One wisp of cotton.
Feel it on this hand.
And she was right. That is when I touched her with my wisp of cotton. I did not use an overt amount of pressure. So she has good sensory in those areas. Next, I will use a pitchfork. I will tap it on the heel of my hand, place it firmly over a interphalangeal joint of my patient's finger, and then I will test it over an interphalangeal joint of her big toe. I'll ask the patient what she feels. I'll ask the patient to tell me when the vibration stops and when the pitchfork, and I will touch the pitchfork to stop it. If sense is impaired, I will proceed to more proximal bony structures such as the wrist, the elbow, or the patella. Ding! Can I have your finger? When did you feel the vibration stop?
Now.
She was a little delayed on that reaction. Let's go to her wrist. Ding!
Now.
She passed that portion of the exam. Can I have your foot? Ding!
Now.
Oh, you passed that portion of the exam. We will not have to go up to her ankle. Next, I will go to the joint position sense. I will grasp this patient's big toe. I will hold it by its sides between the thumb and my index finger and pull it away from her other toes. And then I will state that I'm moving the toe up and down. After I state that, I will ask the patient to close her eyes and move her toe up and down. She will state which position the toe is going. Okay. I have your big toe. Can you feel this?
Yes.
Okay. This is going up
Yes.
and this is going down. Can you please close your eyes?
Up. Down.
She has good positional sense of where her toes are. Thank you very much.
You're welcome.
I would repeat this test several times. If position was impaired, I would move approximately to the ankle. Next, I will do the discriminative sensations. There's a 2-point discrimination. I will use 2 ends of an open-ended paper clip, touch a finger pad in 2 places simultaneously. Alternative, the double stimulus irregularly with a 1-point touch. As I do this, I will be careful not to cause pain. So I'm going to touch you, and I don't have a paper clip in my house. So I will touch you, and can you, no, give me your hands. Thank you. I'm going to touch you, and tell me if it's 1 point or 2.
2. 2. 1. 2. 1.
So the patient was able to sense the multiple sensations and say when they were different. Next thing we'll do is the dermatome. It will help to localize the neurologic lesions, if she has any, to a specific level of spinal cord, particularly in spinal cord injuries. Since my patient has no history of spinal cord injury and has passed all portions of the exam, we will be skipping that. Next, we're going to do the muscle stretch reflexes, deep tendon reflexes portion of the exam. During the assessment, I would have a hammer available. I'd encourage the patient to relax. I'm going to hold the reflex hammer loosely between my thumb and index finger, and I will strike the tendon using a rapid wrist movement. Note the speed, the force, and the amplitude of the reflex response. May I have your knee? Her knee is loose. This is my hammer.
She has a good reflex response.
Next, I will be moving on to the reinforcement part of the reflexes. I'm going to ask you to tighten this leg muscle for me. Okay? It's going to be, but have your foot on the ground. Thank you. So tighten this reflex muscle, and I'm going to hit it with my hammer. Ready?
Yes.
Do you feel that?
Yes.
And if we didn't, so she didn't have any reflexes available when I hit her. Another way to do it is she could lock her hands interchangeably right here, squeeze and squeeze. She had reflex response that time. Next, I'm going to do the biceps reflex, which is C5 and C6. I'm going to hold my patient's elbow. It will be partially flexed. The forearm will be pronated. With palm down, I'm going to place my thumb and forefinger directly on the biceps tendon, and I'm going to aim the strike with my reflex hammer directly towards the digit of the biceps tendon. As you can see, she had normal reflex responses. Next, I will do the triceps reflex. The patient is going to be sitting again. I'm going to flex her arm at the elbow with the palm towards the body. Right here. Thank you. Right here. I'm going to pull it slightly across the chest, and I'm going to strike the biceps tendon with a direct blow behind and just above the elbow, so about right here. And I'll watch for a contraction of the biceps muscle and extension at the elbow. And I saw a contraction, which is normal. Next, I'm going to check the brachial adialis reflex. The patient's hand should rest on the abdomen or the lap with the forearm partially pronated. So right here. I'm going to strike the radius with the point of the flat edge of the reflex hammer about 1 to 2 inches above the wrist. I'm going to watch for a flexation of this and supination of the forearm. Yeah, that's the reflex it should have. Perfect. She shows normal reflexes. Next, I'm going to check the quadriceps, the patellar reflex, L2, L3, and L4. The patient can be sitting or standing, and we've already done this one, but we're going to do it again. I'm going to place my hand on the patient's anterior thigh to feel this reflex. Is it okay if I touch her thigh? She had a normal reflex response, and my patient was sitting. Next, I'm going to do the Achilles or the ankle reflex. This is partially S1. If the patient is sitting, partially dorsiflex the ankle of the foot. Persuade the patient to relax. I'm going to strike her Achilles tendon and watch and feel for plantar flexion at the ankle. Find a few. Okay. So yeah, I go down here, and I'm going to hit it right here at the Achilles tendon, and her foot did flex upwards. Next, I'm going to check the clonus reflex. I would test this reflex if the other reflexes in this test were hyperactive. And how I do that is I would support the knee in a partially flexed position. My patient doesn't need this, but I thought it would be good to go over it. I'm going to support the knee in a partially flexed position. I'm going to dorsiflex and plantar flex the foot and maintain it in this dorsiflexion. I'm going to look and feel for any oscillations between the dorsiflexion and the plantar flexion. Normally, the ankle does not react to the stimulus. So bring it up, there should be no reaction. There may be a clonic beat if the patient is tense or has exercised. Therefore, if I moved her hand up and I moved her plantar flexion up, there might be beats of clonus. The patient doesn't have hyperextended reflexes, but I just thought it would be good to go over. Next, I'm going to do the cutaneous or superficial stimulation reflexes. I'm going to test the abdominal reflexes by lightly but briskly stroking the side of the abdomen, T8, 9, and 10, and below T10, 11, 12, in the umbilicus in the directions illustrated. We go inwards and upwards. And as I run my fingers down and then back up, I should feel a reflex in the abdominal muscles. You mind? Thank you. And I did feel a reflex in the abdominal muscles. The last reflex we're going over is the plantar flexion response, which is L5 and S1. With a key, a wooden end of an applicator stick, or the end of a tongue depressor blade, I'm going to stroke from the heel and move up to the small toe to the ball of the foot. So I'm going to go up. Using the lightest stimulus, that will provoke a response, but increase firmness if necessary. I will observe the movement of the big toe, normally plantar flexion with the toes curving down and inward. Dorsiflexion of the big toe and the fanning of the other toe is present, and that's a Babinski's response. And that comes for a lesion on the central nervous system, so that's why we're testing this. Lift this up your foot. There we go. So at first, my patient did have a little bit of a Babinski response, but when we tested afterwards, she did show normal responses. I think she was just nervous and tense, and when I did it the first time, she instinctively jerked back. That will conclude our test assessment. Before you go, I have a few health promotion activities I would like to discuss with you concerning the neurological assessment we just did and how to prevent any neurological disorders. Is that okay with you?
Yes.
Perfect. Health promotion would be to go to the doctor if you have any type of ongoing headaches, a head injury, dizziness or vertigo, weakness, either generalized proximal or distal weakness, numbness, loss of sensation, fainting and blacking out, seizures, tremors, or involuntary movements. You could also obtain a yearly neurological assessment to prevent neurological diseases from occurring. Keep up to date on your vaccinations to prevent neurological dysfunction. Wear a helmet if you ride a bike or a motorcycle to avoid any kind of neurological damage. And lastly, take measures to control your blood pressure, your cholesterol levels, and your diabetes mellitus to reduce your tobacco use and to promote overall healthy eating patterns and physical activity. This prevents primary stroke and prevention of neurological disorders.
Okay,
And just keep those in mind. Thank you for coming in for an assessment.
no problem. Thank you so much.